Now, let me start with issuing two caveats. The first caveat is that the mere presence of coronary artery disease is not an indication for CABG, and every patient by default must be scheduled for medical therapy, and only by design we must prescribe an intervention in these patients. And the second caveat is, just as is true for pediatric cardiac surgery, that a baby is not a small adult, so is in diabetes. CABG in diabetes, the whole is not just the total of the sum parts. It is not that you do a CABG and you just control the blood sugar. These are altogether a different set of patients. Etiopathologically, they have poor coronary reserves, microvascular dysfunction. Anatomically, we find they have large necrotic cores, a lot of inflammation, aggressive atherosclerosis with diffuse distal involvement of small caliber vessels. And that is a typical angiogram of a diabetic patient, which Dr. Shah also showed. Functionally, we find that even if the ejection fraction in these patients is normal on echo, they have reduced volumes, emptying fractions of the atria, their global longitudinal and circumferential strains are reduced. So every patient should be taken as having an underlying diabetic cardiomyopathy, even if the obvious ejection fraction is normal. And then clinically, they present late with atypical symptoms, they have more LV dysfunction, and therefore these patients need to be worked up very thoroughly preoperatively. We must rule out involvement of other subsystems, CNS, peripheries. We must look for carotid, subclavian, abdominal bruits, abdominal masses, and do a good assessment of the pulmonary functions. Renal function should be thoroughly investigated. Proper hydration in the preoperative period should be ensured, and all nephrodroxic drugs should be withheld preoperatively. If the patient is elderly, symptomatic with history of TIA, has a carotid bruit or multi-system involvement, and if the patient has a left main stenosis, almost 12 to 16% may have an associated carotid artery disease. Therefore, a carotid Doppler study in these patients is mandatory. Also, we find that in any surgery, any form of stress, the patient enters into a catabolic state with increased hormones, new glucogenesis, glucogenolysis, ketogenesis. All these things increase the blood sugar levels. On the top of that, there is reduced insulin secretion, there is insulin resistance, and some of them may even we need inotropes, which may jack up the blood sugar level, thus creating a state of hyperosmosis and acidosis. It leads to increased infection in these patients, and because of overactivation of collagenase, we find that even the wound healing in these patients gets delayed. Now, how much the sugar should be managed? We know both hypo and hyperglycemia are harmful in these patients. So somewhere between 140 and 180 should be the preoperative, intraoperative, and the post-operative sugar levels, which are managed with a continuous insulin infusion. Now, though Syntax score has been shown to predict MACE in PCI patients, they have not found any relevance in CABG, and therefore they should not be utilized. Similarly, FFR has as yet not been proven in CABG, as has been shown by the Fargo trial and a meta-analysis of PHI trial. It has not improved the outcomes. So the results of the Graffiti trial, which is having a head-to-head comparison of an FFR-guided CABG versus angiography, cine-angiography-guided CABG, they are awaited. So currently, the decision-making is essentially on the extent of CAD, on the symptomatic status of the patient, on the presence of LV dysfunction, comorbidities, and also what are the patient's personal preferences in these matters. If you look at the European guidelines, though Dr. Shah did say low Syntax score, angioplasty is preferred, but if you look at the guideline, even with a Syntax score of less than 22 with diabetes mellitus, CABG is class 1A indication and angioplasty is class 2B. That's the guideline, which are the latest guidelines. A word or two about certain technical aspects, what conduit to use. It has been shown that arterial grafts, there is no differences in patency rate between diabetic and non-diabetic patient. But when we look at the venous grafts, then the patency, both at 10 and 20 years, is inferior in diabetics as compared to non-diabetic. So obviously, arterial grafts are preferred. Now, single versus dual memory, we all know bilateral memory in a lot of observational studies and registry data have shown to improve long-term survival, but it also runs the risk of increased deep sternal wound infection and mediastinitis. And this is especially true for patients with insulin-dependent diabetes, morbid obesity, and COPD. So it is recommended by the European guidelines that we must use IMA or internal mammary artery in a skeletonized fashion. See, normally what we do is we take an IMA as a pedicle, which is almost an inch wide, consisting of the IMA, that is internal mammary artery, the accompanying vena comitaentis, fat fascia. But if you take out the skeletonized IMA, leaving behind the vena comitaentis and fat and fascia, we reduce the sternal infection rates and we get increased length by which we can do composite grafting and we can do total arterial revascularization. However, in patients who have got very high risk of deep sternal wound infection, alternative conduits like radial artery, the gastroepiploic artery, and the inferior epigastric arteries can be used, and they have been shown to have better results than saphenous vein. Off pump versus pump, Raza et al. Shown that there is no difference between the two, but it is proven beyond doubt in a meta-analysis of 17 studies that off pump and aortic bypass, that is where the top ends are not placed on the aorta, it reduces the CV rate and it reduces the mortality by almost 40 to 50%. Minimally invasive CABG, very limited indication has been given in the guidelines for only Lima 2 LAD, but the process is evolving. But the important thing is that it should be done where expertise exists. And because of diffuse atherosclerosis, one should be a little wary of using minimally invasive techniques in CABG and diabetics. My slides have stopped. Okay. And we have a trial coming up, which is the MISS trial. The results are waited, which is looking at sternotomy versus minimally invasive, a randomized controlled trial, and that might guide us better to the state of minimally invasive surgeries. Endoscopic conduit harvest, it is shown to reduce the infection rates, but the patency rates of the graft is very controversial. Some saying it's good, others not agreeing with that. But the European guidelines give it a class 2A indication, but once again in expert hands. What about outcomes? Now, short-term outcomes, in a lot of observational studies, they've said there is no difference between diabetic and non-diabetics, as has also been shown in this RCT between diabetic and non-diabetic and between NIDDA versus insulin-dependent, there was no difference. There was no difference in in-hospital mortality also, but long-term mortality was increased in diabetic patients. You can see the long-term mortality at 13 years was much higher in diabetes versus no diabetes and versus insulin-dependent versus non-insulin-dependent diabetes. However, there are some studies, including the Syntex trial, which showed that the long-term results also were no different if you use IMA to the LAD. But the balance of evidence, the weight of the evidence, if you look at meta-analysis of 11 trials, that the long-term mortality increases with diabetes. What do you do with a patient who has what we call as no option, diffuse atherosclerosis? Well, we can do an endarterectomy. An open endarterectomy is much better than a closed endarterectomy. You lay open the entire length of the coronary artery, take out the whole plaque, and then lay a IMA onlay patch rather than a saphenous vein onlay patch. Now, these results can be excellent. Look at 1 year post onlay endarterectomy, beautifully reconstructed LAD. Then there are recent advances in terms of venous revascularization. You can't revascularize the artery, then you put a bypass graft on the accompanying vein and you ligate the opening of the vein into the coronary sinus. And because the coronary circulation does not have any vein, you will retrogradely perfuse all the layers of the myocardium. So that can be done. And then these new advances, which are not clinically available, of connecting the floor of the coronary artery directly to the LV cavity, can revascularize the artery. So along with this, ladies and gentlemen, it's very important to do cardiac rehabilitation, which is class 1A, and aggressive secondary prophylaxis and lifestyle interventions cannot be overemphasized. The role of holistic medicine and complementary role also is very important. So to conclude, ladies and gentlemen, medical treatment should be by default, CABG only for a limited subset of patients. We must optimize the subsystems preoperatively. Arterial conduits and an aortic OPCAB is the best, and these patients need good rehabilitation and secondary prophylaxis. Thank you very much, sir.